we're going to be discussing one of the more controversial trials presented at ASCO, which is the SONIA trial. CDK4/6 inhibitors have been hugely successful in treating metastatic estrogen receptor-positive breast cancer, but a long-standing question has been whether or not they should be used as a first-line therapy, which is given first for a patient's treatment plan, or as a second-line therapy, which is where people receive a new drug after their first treatment regimen fails them. This question is important because although these drugs are approved for both first and second line use, there have been no studies which directly compare which treatment strategy is most effective. This phase 3 trial was conducted in the Netherlands and recruited 1,050 patients with metastatic estrogen receptor positive breast cancer, which means that their breast cancer has spread throughout their body. This study looked at two important treatment approaches. The first is limiting hormones that drive breast cancer growth and progression using hormone therapy. The second is preventing breast cancer cells from dividing using CDK4/6 inhibitors. Patients were randomized to receive one of two treatment approaches, which is either the standard of care or the standard of care plus fulvestrant. The first group focused on getting the treatment earlier and received aromatase inhibitors, which is a kind of hormone therapy, plus CDK4/6 inhibitors first. The second group received the standard of care therapy, and then they received the CDK4/6 inhibitors after their disease progressed. They found that there were no differences in outcome when CDK4/6 inhibitors were given as a first-line or a second-line therapy. But they found that the patients who received them as a second-line therapy did not need to take them as long as those who took them in the first-line setting. And these people had fewer adverse events or negative reactions to a drug, which can range from anywhere in severity from feeling mild nausea to acquiring heart or lung damage. An additional win of this study and the findings were that due to the shorter time needed for taking CDK4/6 inhibitors as a second-line therapy, the researchers estimate that this led to cost savings of about $200,000 per patient. Now, this all sounds great, doesn't it? However, there are some caveats. We spoke with Dr. Erica Hamilton about what patients need to know about this study and what some of the concerns are surrounding the findings.
There were still, I think, a lot of questions left in many of our minds after the presentation of this abstract. I can name just a couple, points that I think a lot of people were considering. First, to me, it looked like in the first line that the standard of care arm, aromatase inhibitor alone, did a little bit better than we would have expected. So most of our trials are about 12 months with AI alone, about doubling 24 months with CDK4/6. And for some reason in their trial, AI alone did well for 16 months. So we lost a little bit of perceived benefit there. Their trial really wasn't that large. They had about 500 patients in each arm. So compared to the body of evidence we have with overall survival for CDK4/6 inhibitors among multiple trials in the first line setting with, each trial having 5,000, et cetera, patients, this really was a pretty small trial. The trial was actually powered for superiority, but they kind of reported it as inferiority. And so there's a little question around the statistics there. And then, just looking at the curves for me, it did cross one. It wasn't statistically significant, but there was a little bit of a trend towards patients that had CDK4/6 inhibitors up front doing a little bit better. And so when you put all that together, I don't think that necessarily this is going to be practice changing in the United States. I think it may be in countries where they have less access to drugs, where cost of care is a really big issue and can really determine approval and reimbursement strategies. But I'm not 100% sold based on this trial that we should not be continuing to give CDK4/6 inhibitors upfront in the first line setting. I think, to really change people's mind, ultimately, we're probably going to also need a trial that wasn't palbociclib. Certainly, palbociclib is the one CDK4/6 inhibitor that we have that hasn't shown overall survival. So for this study to be based on palbociclib, I think many of us wonder maybe if we would have seen something different with abemaciclib and ribociclib. So really putting everything together, both the fact that the CDK4/6 patients up front did a little bit better, the fact that it was a small trial, the fact that the control arm performed a little bit better than we would have thought, and the fact that it was a palbociclib-based trial when really we tend to probably be using less palbociclib now first line, leaves a lot of questions in people's minds.
While the results of the SONIA trial were interesting and warrant further conversation, it is still unclear who the ideal candidates are to receive CDK4/6 inhibitors in the second-line setting. Now, not to be redundant, but our mantra is, as always, more research is needed. We encourage patients to discuss with their doctors about the course of treatment that is right for them and to consider clinical trials as an option.